Hello, welcome to part 2 of my lecture on squamous cell abnormalities on cervical smears, in which I shall be talking about ASC-H, HSIL, and squamous cell carcinomas. To begin with, I shall bring back one of the slides from the previous lecture in which I have explained that why I like to look at squamous abnormalities in two major halves. When the nuclear abnormalities, which define these lesions, affect cells that resemble superficial and intermediate squamous cells, we categorize them under ascus and low-grade CIL. Whereas when they affect cells, which would be otherwise metaplastic or parabasal cells, we call them ASC-H and HSIL. We've already dealt with this half in lecture 1, and today we are going to deal with the other half. But along with it, I shall be also speaking about squamous cell carcinomas just to complete this particular segment. So, to begin with, let's look at atypical squamous cells where a high-grade lesion cannot be excluded. Short form is ASC-H. ASC-H by definition describes changes which suggest high-grade CIL, but a definitive diagnosis is not possible. The number of cells usually is scanty, but not necessarily scanty, as you are going to see in the subsequent slides. There are two major cytologic patterns. There could be small cells with high nucleo-cytoplasmic ratio, also called, according to Bethesda, as the atypical metaplastic cell pattern. However, there is another one which is called the crowded sheet pattern, which of course underlines the fact that the cells are not necessarily sparse. In the atypical metaplastic cell pattern, we find cells which resemble metaplastic cells in their size and shape. The nuclei are about 1.5 to 2.5 times larger than normal metaplastic cells or parabasal cells. The nucleo-cytoplasmic ratio approaches that of HSIL but doesn't reach that of HSIL, which is a little bit difficult to comprehend because all cases of HSILs do not show a very high NC ratio. We are going to see that a little bit later. There are variable degrees of nuclear membrane irregularities and hyperchromasia, and these irregularities would be a little bit lesser and the hyperchromasia is going to be a little bit less if you're talking about hyperchromatic cells as compared to HSIL. So it just falls short of HSIL. Similar kind of issue we have seen when we try to analyze the differences between ascus and low-grade cells. So in the atypical metaplastic cell patterns, we have few of these cells which are metaplastic cells. They show some degree of hyperchromasia. In this, because of the projection possible, looks a little bit more hyperchromatic than what really are. The nuclear membrane not that irregular. We are not confident enough to call it HSIL. There is a background of changes which look like from a smear with atrophic changes, which can also show some nuclear abnormalities. We are going to discuss about that again during the course of this particular lecture. So we are not very confident in calling it as HSIL, so we call it as ASC-H. In this particular picture of ASC-H with the atypical metaplastic cell pattern, we again find cells which are otherwise look like metaplastic cells, show some degree of chromatin abnormalities, some degree of nuclear membrane irregularities. We are not absolutely certain that whether we can call this, or we are not confident enough to call this HSIL. So we just fall and stop short and just call it ASC-H. Another situation where we call something ASC-H would be cells where the chromatin pattern and the nuclear irregularity would be otherwise enough to call it a high-grade cell. However, the number of cells are extremely few. Maybe you see one or two cells like that where we are not very certain. So we don't call it H cell. We just stop short and call it ASC-H. So these are the situations where the number of cells are extremely few. Another example of an atypical metaplastic cell pattern where the number of cells are few, like this cell over here, a rounded cell, some degree of chromatin abnormality. We feel that this might be H cell, but just because the number of cells are very few, this one, we fall short and call it as ASC-H. Some might consider this enough to designate this smear as that coming from a H cell. The next pattern in ASC-H is far more difficult to really put our foot down and interpret, and that's why we call it ASC-H, is the crowded sheet pattern. In this, we find a very tight aggregate, which almost looks like a mini biopsy of crowded squamous cells with atypical features, some degree of loss of polarity. We look at the cells at the edges. We are not very confident to call it a high-grade cell. As you know, we are going to see that high-grade cell can also show a crowded sheet pattern. So not exactly certain, and so we decide to just leave it as ASC-H and not call it high-grade cell. This picture is a representative picture of ASC-H crowded sheet pattern from the Bethesda Web Atlas, and the next one is from one of the cases which I have come across during the course of routine reporting. So we have metaplastic cells. We look towards the periphery, we see some cells with hyperchromasia. Here we are unable to make out the morphology of the cells very clearly, right over here too. So we call it ASC-H, and this is ASC-H. We call it ASC-H, but this is the one which would be representative of a crowded sheet pattern. Next, we move on to high-grade squamous intraepithelial lesions, HSILs, right? Now, these lesions can come in a variety of flavors. There is a wide range of wide array of morphologies, and we are going to see them one after the other, as a result of which it can lead to a considerable amount of diagnostic difficulties. But just to go through the list, just to summarize what we might be seeing or what we are going to see in the next sequence of slides, let us just summarize the findings on a single slide. The cells generally resemble metaplastic or parabasal cells. But then look at the variations. The cells can occur singly, they can be found in sheets, or they may be found in syncytial aggregates. They have a high nucleocytoplasmic ratio, but that nucleocytoplasmic ratio can be extremely high with an almost imperceptible amount of cytoplasm, whereas in certain cases we see a little bit more cytoplasm, and as a result of which the cells may resemble cells which would be otherwise equivalent to a severe dyskaryosis, or so-called CINII, when the amount of cytoplasm is extremely scanty, or it can be something which is equivalent to a moderate dyskaryosis, CIN2, where you see a little bit more of cytoplasm. Okay, so this is just as a rough way of looking at it, but there are a lot of differences and other variations and exceptions. Next, chromasia. This is very interesting. The chromasia, the chromatin, the amount of chromatin in HSIL is not necessarily always hyperchromatic. Hyperchromatic, yes, many of the cases indeed show hyperchromasia, but cells in HSIL can be hypochromatic, that is the pale cells. They could even be normochromatic. So in such circumstances, when the cells are hyperchromatic or normochromatic, we rely more on other features, one of them being nuclear membrane irregularities. The chromatin can be granular or it may even be evenly distributed. Irregular nuclear contours may be seen, and this helps when the cells have a hyperchromatic or normochromatic pattern, and it also shows indentations and grooves. Nucleoli are absent, but please remember that when HSIL involves glands, nucleoli may be found. Even the characteristic features of the character of the cytoplasm may be extremely variable. The cytoplasm may be lacy, it can be dense, or could even be keratinized. So let's look at the different kinds of morphological appearances of HSIL. Here we have a HSIL with about a moderate amount of cytoplasm. The nuclear chromatin is pale with opened up chromatin, but the nuclear membrane showed remarkable degree of irregularity, giving the appearance that resemble raisins, and that's why the phrase which is often used to describe these cells are cells with raisinoid nuclei, to underline the fact that the nuclear membrane are extremely regular and represented also as folds within the nuclei. Here we have a case where instead of hyperchromasia or pale chromatin, you've got very dense chromatin. The nucleocytoplasmic ratio here is much higher, right? You see something which looks like cilia, but trust me, these are not cilia. Maybe it has come out like this on this particular smear. We went and looked at it because of the projection, but this is a high-grade cell with a high nucleocytoplasmic ratio and hyperchromasia. Now, sometimes the HSIL cells can have opaque cytoplasm, or it can have pale cytoplasm, and here in this particular picture here you have both kinds of appearances of the cytoplasm, both opaque as well as pale cytoplasm. This is a HSIL with a lacy pale cytoplasm. As you can see, the nuclei over here are they show marked the irregular chromatin, some areas with cold pale chromatin, generally irregularly clumped chromatin with irregular nuclear outline. The cells are rounded. They may have a vague resemblance to endocervical cells, and if you are not aware of it, you might mistake them as some kind of a glandular abnormality, but these are cells from HSIL. Most of the cases which will be shown today are cases which have been proven to be HSIL on subsequent biopsies. Right, this is a case of HSIL with keratinization. HSIL cells can show marked amount, quite a significant amount of keratinization. As you can see over here, very tight aggregate of cells. Keratin here, the cells have very angulated, sharp outlines, almost looking like cells that you would see, the spindle-shaped cells, that suggesting that possibly there is an invasion. And here a more rounded cell with keratinization. So the amount of keratinization can be very variable. Right. Now here I would like to show something else. In certain situations, the amount of cytoplasm in HSIL cells a little bit more than what we expect, what we have seen so far. Right. So this shows moderate amount of cytoplasm, otherwise metaplastic cells. This is what corresponds to CINII or moderate dyskaryosis if you are using that system, right? So in the Bethesda system, CINII, moderate dyskaryosis, and CIN3, severe dyskaryosis, are clubbed together under the same phrase, HSIL. So if you have a HSIL which corresponds to CIN2, we are going to have cells with more cytoplasm. As you can see, the nuclei over here, extremely hyperchromatic, irregular nuclear outline. So you can safely call it HSIL and not LSIL, where the cells are more of the morphology of a superficial and intermediate squamous cells. For example, if you would have cell these changes in the cell over here, we would have called it a low-grade cell. And low-grade cells and high-grade cells can coexist in the same smear, of course, and you call it high-grade cell, the higher one you call. Another example of a HSIL with a lower nucleocytoplasmic ratio corresponding to CINII moderate dyskaryosis. The cells are here tightly clustered. As you can see, the nucleus over here showing some indentation and abnormal chromatin, as you can see over here. So this again is HSIL with a lower nucleocytoplasmic ratio corresponding to CINII. So this is just a comparative picture. This is what HSIL corresponding to CINII would look like, and this is what HSIL corresponding to CINII is going to look like. Now, next, how are the cells arranged? HSIL cells, as you have seen, can be just single cells, clusters, or small groups of 1, 2, 3 cells, as you have seen in some of the previous pictures. Whereas in this case, the cells are present as a syncytial aggregate with sharp edges. If you look at the nuclei, the nuclear chromatin is abnormal. There is marked degree of nuclear membrane irregularities, and HSIL cells may be present like this. And here is a cell which is keratinized. Here we have another aggregate of cells of HSIL, where you have got some parts of the cells have got rounded edges, whereas certain other parts have got sharp edges. Now, the problematic cases of HSILs come when we find HSIL as a hyperchromatic crowded group. You have to look at the edges of the cell, at the edges of these aggregates or groups, and you can see that at the edges the cells look like metaplastic cells. Some of them have some kind of a rounded appearance, and whenever you see a round cell, we start thinking that are we dealing with a glandular abnormality or a squamous abnormality, and there can be a lot of difficulties. And when people, experts with many years of experience are shown cases of hyperchromatic crowded groups, there is a lot of discrepancies between the opinion. However, there are certain features which are thought to be of help most of the time, but not always. And if you have a hyperchromatic crowded group, and in the center there is a kind of a hyper tightening of cells with a feature of like something which suggests a whirling pattern, that is one of the features which helps us say that this is an HSIL in a hyperchromatic crowded group. You also look at the edges of these aggregates. If you have sharp edges, it favors the fact that it is an HSIL over it being a glandular lesion. And of course, you look at the cells at the edges, you are going to see that they are elongated, kind of oval cells, right? These cells over here, this look clearly metaplastic. So when you put all of these together, they help us call them as HSIL in a hyperchromatic crowded group. However, in the diagnosis, you just call HSIL. This is just for our understanding, for our concept. Okay, we do not like HSIL in hyperchromatic crowded groups, not exactly a diagnosis. The diagnosis is HSIL. This is just a morphological feature which we should know how to identify. Another HSIL in the hyperchromatic crowded group cluster, right? And so you can see some of the sharp edges over here. Looks extremely glandular. It could sometimes happen when HSIL involves the gland. This could be one of the situations. However, I'm going to show other slides which are more characteristic of HSIL directly involving glands. This could be, of course, one of them. Right. So HSIL in hyperchromatic crowded group. Let's look at the summary of features. Please excuse the typo over here. Flattening of the edges at the cell aggregates, as I have mentioned. Whirling and hyper tightening of cells at the center. Distinctly polygonal cells. Cells with marked hyperchromasia. Cells with polygonal to even plump spindly nuclei. These are the things which you'll be able to make out when you look at the periphery. If you might be able to pick up mitosis within the aggregates. Now that would help you to call this as a pre-neoplastic lesion rather than a benign lesion. And of course, lack of glandular architectural features which like pseudostratification, feathering and roseting, which helps us to say that this is possibly something from an HSIL and not from a glandular abnormality. However, there are certain exceptions to this rule when HSIL involves gland, as you are going to see shortly. And please remember that nucleolar prominence may be present in high-grade cells. So whenever you see a prominent nucleoli, it doesn't necessarily mean that we are dealing with a glandular lesion. Now this is what sometimes HSIL with glandular involvement looks like. These are extremely difficult cases to diagnose. Okay, you need to see a lot of cases and you have to gather a significant amount of experience not to be mistaken these clusters as glandular abnormalities. You have to look at the cells towards the periphery. You see the flattened cells. It can show the creation of gland-like acinar structures. But when you look at the cells at the periphery, look at this cell over here. This is a clearly metaplastic cell. The nucleus is oval, pulled out a little bit, hyperchromatic, right? And when you see all these features together, these indicate that we are dealing with a HSIL with glandular involvement. It is a big diagnostic problem. One more example of HSIL with glandular involvement. Look at the straightening of the edges, a hyper tightening at the center. As you look at the cells towards the periphery, you look at this metaplastic cell over here with hyperchromatic nucleo. Look at this cell. This is a classic HSIL cell, but then to do that, you have to move your attention towards the periphery of this lesion. Look at this one, elongated, hyperchromatic. Some cells shows significant degree of N-isonucleosis. So this is another example of HSIL with glandular involvement. Another example of HSIL with glandular involvement. Here you see it actually produces a gland. Here is showing some degree of elongation too, which means that which indicates that it's possibly a glandular lesion, but it is not. It's creating a gland. And sorry about that. Sorry about that. And we have these structures which are those resulting from HSIL involving the glands. Right. So this is, I like this, I picked it up during the course of reporting. This is a beautiful example of a HSIL. If you see just this part of the cluster, this is a high-grade cell, and this is just going into the gland. So this is a columnar cell. So this is a pretty good example of what the HSIL does when it goes and involves the gland. But most of the time, things are not so clear. This is a very, very rare occurrence too. But if you find one of these in a smear where you are otherwise undecided, it definitely helps you with diagnosis. Right. Another thing to remember, which could be a pitfall, is that when HSIL involves glands, it might cause tumor diathesis, as a result of which you might mistakenly call it as an invasive squamous cell carcinoma. There are cases like this where you see a lot of HSIL cells, you see some degree of tumor diathesis, but most of the time that tumor diathesis will be associated and adding to the cells, and the background will be otherwise clear, and that should help. But of course, when you see HSIL cells with tumor diathesis, you tend to call it an invasive cancer, but it is not always invasive carcinoma, especially when the other areas of the background are clean, and these are actually HSIL involving glands, and when it does so, it may lead to some necrosis which comes on the smears. So HSIL with glandular involvement, again, what helps to differentiate from glands, it shows whorling at the center of the aggregates and flattening at the periphery. Nucleoli, as I have said, may be prominent, so do not use nucleoli to differentiate between HSIL and glandular changes. Pseudostratification of nuclei and palisading may be noted. Pseudostratification and palisading are things which are considered to be almost synonymous with the cell showing glandular differentiation, but Well, it is not uh, always the case, and when HSIL involves gland, it picks up those features of glandular lesions. So please remember that. And as I've just said, it might cause tumor diathesis if it involves the glands. And of course, never forget that HSIL and adenocarcinoma in situ might coexist, okay, in the same specimen. So that is something which, so if you see both features, it might be that both of them are present. Now, let us look at some of the other difficult patterns associated with HSIL. Now, I have seen a few of these, but unfortunately, I couldn't retrieve them from our archive, so I have to rely on a picture from the Bethesda Web Atlas. HSIL may show some abnormal strip nuclei. You cannot call these as HSIL because there's no cytoplasm. However, if you look carefully, you are going to find typical HSIL cells. So HSIL may produce abnormal strip nuclei. HSILs can sometimes show very sparse and singly scattered cells, okay, very few cells. And as I have said, when you have cells which look like HSIL and there are a number of cells are very few, one might like to call it ASC-H. But if you see a cell which is as abnormal as this one, even if you see one or two cells like this with such a high nucleocytoplasmic ratio, a rounded cell with hyperchromasia, with a very abnormal chromatin, indentation of the margin, okay, so these are the ones which can be very easily missed, and HSIL known to have these kind of, known to show these kind of singly scattered cells at times. So thus there this so-called pitfall alert. This is something which we don't see that often nowadays because we only look at liquid-based cytology, but in the days gone by when we used to see conventional preparations, we used to see this pattern of HSIL getting arranged in a linear pattern along mucous strand. This again is from the Bethesda Atlas. The next thing which I am going to talk about is presence of HSIL in a background of atrophic changes. One of the most difficult things in cervical cytopathology, because atrophic changes can be pretty remarkable as far as their effect on the nuclei are concerned, right? The nuclei can be extremely hyperchromatic. You can sometimes see irregularity of interior margins. You can see some high NC ratio. And so if you do not keep that in mind, you are going to call a big number of smears with atrophic changes as those with some squamous abnormalities like low-grade CIL or high-grade CIL, ASCUS, ASC-H, etc. So we have to be very, very careful not to over-interpret these cases as those with squamous cell abnormalities. Now, you need to look for nuclear irregularities. If you see a significant amount of nuclear irregularity, it means that we are dealing with a high-grade cell in a background of atrophic changes. So look for nuclear abnormalities, irregularities, I'm sorry, beg your pardon. Look for the presence of coarse chromatin, and I would rather say irregularly clumped chromatin as compared to the smudgy chromatin that we see in atrophic changes. And the third point is something which I cannot really demonstrate in a presentation like this. But if you try and focus, if you focus on a single plane, and on that plane, in one plane without, on a single plane, if you find overlapping nuclei, that suggests that we are possibly dealing with HSIL. The other thing which helps in aggregates are the presence of abnormal polarization of cells at times. However, this is what is been taught. However, I'm going to show you a number of cases where classic atrophic changes show that the nuclear polarization are not that good. So let's look at this one. So here we have a case which is an atrophic smear. You've got this cell with a high NC ratio, a very regular nuclear membrane. We can see this change over here, this degree of change over here in an atrophic smear. I'll call it negative for intra-epithelial lesion or malignancy, atrophic smear. If I see this in a case which is not atrophic, okay, I might call this as ASC-H, but not in this case, right? Now look at this one here also. You see a slight amount of nuclear irregularities. Otherwise, the chromatin is pretty good. Again, in an atrophic smear, sometimes you can have a tendency towards the nucleus going into pycnosis, kind of a changes. So degenerative changes. So these are all features due to atrophy. Here again, it is not really shown up pretty well. A group of cells, it looks hyperchromatic, but these were actually kind of a smudgy kind of a chromatin. So again, here we would not call this as H cell. However, here in this case, I think there are two cells together, or maybe yeah, I think they're overlapping. But here there is a very high NC ratio, and this nucleus is too pleomorphic. Okay, so something that bad. Even this, some people might not call it a cell, but just ascribe it to some changes. But this would be something which I would possibly call H cell. I wish I could bring in some more slides to show you what a degree of abnormality enough to call it H cell would have been, but unfortunately I don't have that. But just to underline the fact that atrophy can show a significant amount of changes. So under the premises of nil. So don't just call things ASCIL or ASC-H in an atrophic background unless and until you're thoroughly, absolutely convinced. And some of the points you mentioned in the previous slide should be of help, right? The next group is another very difficult group. Fortunately, it's pretty rare, and that is ASCIL resembling repair cells. Just forget the typo of this. I don't want to put the number 9. This is something else. I actually planned to put it as a number 1, 2, 3, 4, 5. So this came in one of the initial kind of type, so that's an error. So just don't get distracted by this number. Just ignore this. So H cell resembling repair cells. So these cells have a polygonal shape, moderate amount of cytoplasm. So this is something which looks like CINII, right? And pulled out cytoplasmic edges with prominent nucleoli. And this would be one such example. So you have got this cell, which other metaplastic cell, pulled out edges, right? But as compared to a typical repair, the cells are extremely hyperchromatic, right? And there is some degree of possible nuclear membrane irregularities. So here it would be an H cell who resemble repair cell. I've got another one which a more cytoplasm but much more pleomorphic cell, and you can see here the polarity is completely deranged. Some of the cells have whereas over here you can look at the cell and look at the cell over here. So this again is something which I'm going to call H cell, which is H cell, and they resemble repair cells. Now there are other examples that I'm going to show what is exactly a typical repair and what is an atypical repair. Some might like to ask me that why this is not atypical repair, where I'm going to show you a slide in which I'm going to here there is a tremendous amount of nuclear overlap, lack of polarity, and the pleomorphism a little bit too much, right? So I would call it H cell. Some might disagree. Now, these are typical repair changes. Okay, you see degree of hyperchromasia mostly due to overlap. In a typical repair, the chromatin is opened up and you can see some small prominent nucleoli in some of the cells if you just move the focus up and down. And otherwise, they are present in the so-called trabecula, or a shoal of fish kind of an arrangement. So this is what a typical repair is. You have seen it in one of the previous talks, and this is what an atypical repair would be. Again, a shoal of fish appear in some disarray, and some of the cells show some degree of hyperchromasia, not all of them. Some might say that this is enough to call it a high-grade cell with a repair pattern, but I would rather call it an atypical repair. An atypical repair, as I have discussed in the previous talk, corresponds to ASCUS. Right. So what are the mimics of ASC-H and H cell? So these are some of the list of differentials that we should consider. So this is the list. Let's look at them one after the other. The first one, of course, is to differentiate between benign metaplastic cells, ASC-H and H cell. So compare metaplastic cell limb, ASC-H and H cell. So these are benign metaplastic cells. You can have a little bit of a hyperchromasia in benign metaplastic cell clusters, pretty well oriented with each other. You can have some kind of intracellular windows between these cells, and sometimes a slightly bigger cluster with a more opened up chromatin, very sharp nuclear outline. You may find a little bit of nuclear membrane irregularity, one or two of the cells, which shouldn't immediately trigger a diagnosis of ASC-H, okay, or HSIL. These are the pictures which you have seen before, I guess one or two of them. These are metaplastic cell, a little bit disoriented, a little bit of overlapping, chromatin a little bit more irregular, right? Some degree of nuclear membrane irregularities. So these are the cases which I'm not really confident enough to put him under the category of ASIL. I'll call it ASC-H. And once again, we have another group of cells over here in which we have got some degree of nuclear membrane irregularities, okay, some abnormal chromatin, not enough to call it high-grade cell. However, when it comes to high-grade cells, this is pretty clear-cut, extremely hyperchromatic nuclei over here, marked irregularities of nuclear membrane. This is somewhere I'd feel confident to call it HSIL, and this you have already seen, the syncytial, the aggregate of cells, okay, which I have already described in one of the previous slides. So just to show you a kind of representation of the differences between benign metaplastic cells, they may show some degree of irregularity. So ASC-H and HSIL. Okay. The next group, again, a picture which taken from the Bethesda Web Atlas. In one of the previous lectures, I have shown you the same one. Most of the times when I see tubal metaplasia, I really don't have much of a problem. The cell nuclei look pretty benign, but sometimes tubal metaplasia can show this kind of cells with some degree of nuclear membrane and nuclear enlargement, some abnormality of chromatin, but you can see very sharp nuclear outlines. Okay, so one might start thinking in terms of either a glandular abnormality or HSIL involving glands, but then when you look at this cilia over here, you're reassured it is just tubal metaplasia showing some degree of atypia. This is not HSIL. Now, this is something much more mundane, can lead to a lot of difficulties. You can have clusters of endocervical cells, right? And especially at a particular plane when you're not able to see the cytoplasm that well, the cytoplasm a little bit scanty. So it looks superficially like an HSIL, right? But if you look at the outlines, you can see how nice and sharp the nuclear outlines are. Absolutely, the chromatin looks pretty good. Periphery looks a little bit hyperchromatic, but maintained polarity, pretty well arranged. So this is what is an endocervical cell with scanty cytoplasm. Looks like HSIL, but when you compare it with the cell on this side, you can immediately see the difference, the isonucleosis, the marked hyperchromasia, and of course look at the fact that the polarity is not at all maintained, right? So just to show you the difference between endocervical cells with scanty cytoplasm and HSIL. Now, endometrial cells can also create a bit of a problem because they create this little round tight clusters as compared to HSIL, okay, so which can also show this tight clusters. But here the endometrial cell, they produce this kind of ball-like clusters. And if you look at the cells at the edges, you'll see this nice round sharp nuclear outlines. So these are endometrial cells as compared to HSIL cells, which are a little bit more elongated, polygonal cells, sometimes even plump spindle cells, and you see that deranged polarity over here. So this is what HSIL looks like. I hope that these pictures help in clarifying some of the concepts of the differential diagnostic problems that we might face when we are trying to call something HSIL, or something if we don't understand, we might even miss HSIL. Now, another problem is that when endometrial cells are singly scattered, sometimes you can have singly scattered endometrial cells which have a vacuolated cytoplasm. But look at the nucleus. It looks a bit hyperchromatic but very sharp edges as compared to the cell over here, which you've already seen before. This is HSIL cell with a very abnormal chromatin. Compare the chromatin here to the chromatin here, okay, with a significant amount of irregularity of membrane. So this is a single endometrial cell as compared to a single HSIL cell. Other problem, which actually a problem with hyperchromatic crowded groups, are fragments of lower uterine segments. Okay, they can look pretty scary, but one of the big hacks or one of the tips which I'd like to provide is look at them at a lower magnification, and you look at the edges. You see these very sharp edges. Sometimes you can have this kind of a geometric edges, right? So when there are very sharp edges, these are fragments from the lower uterine segment, and here you can actually see an endometrial gland coming over. You can see lumina of the gland, and this is the endometrial gland. Okay, and if you look at the other cells, also extremely regular outlines, right? If you look at the periphery, so these fragments of lower uterine segment, which might be mistaken if you're unaware with a hyperchromatic crowded group of high-grade cell. Next, let's look at atrophic smears. We have already spoken about atrophic smears, and atrophic smears can show this atrophic hyperchromatic crowded groups of metaplastic cells, and I have seen a number of times that there is sometimes a kind of a deranged polarity, but what helps me is that this reminds me of some kind of mesenchymal fragment. They're not mesenchymal cells, but you see spindle cells which are enmeshed in a kind of a matrix. So this is a kind of an appearance which we see in atrophic spheres. Some of the cells look very spindly, very smudgy kind of a chromatin. Just compare the metaplastic cells here of atrophy and look at these cells where this kind of a syncytial aggregates, and it looks, you are unable to make out the cell outlines clearly over here as compared to what you do over here, because it looks that the cells are kind of enmeshed in the cytoplasm which lies behind. You can see some kind of changes here. As I have shown this before, you can find alterations in the nucleo with a degree of smudgy chromatin, which looks like HSIL but not HSIL, and look at the chromatin pattern over here. Here we have a degree of nuclear membrane irregularity, which might, give a suggestion of HSIL. If you're not sure, you might just think that irregularity, be safe or try to play safe and call it ASC-H, but almost always these just turn out to be atrophic smears, and sometimes one might like to give them a trial of topical estrogen therapy and the changes come back absolutely to normal, right? And this of course is one picture which I found, which I would consider as somewhere where I would call something HSIL in the background of atrophic changes. Just remember, these are two cells which are just overlapping, so just consider this as one cell and this as another cell. Fair enough to call it an HSIL, and just to complete the morphological variations that we can find. Now, another group of problems, cells which look like HSIL but not HSIL, the histiocytes. Look at the histiocyte here. Okay, you can see the reniform nuclei, and actually most of these cells are histiocytes, right? Very pale cytoplasm, very sharp outlines, and if you have this kind of a reniform nuclei, it also helps. Okay, so histiocytes can look like HSIL, and this is again a histiocyte with a very frail kind of a wispy cytoplasm, and look at the nucleus here with sharp outlines, with the reniform outline. Now, this is very rare. This I picked up from an article published in Diagnostic Cytopathology. If those of you have seen my first lecture, or I guess my second lecture, I had shown this before. This is a cytotrophoblast, which resembles HSIL, and I have to mention a range of conditions in postpartum period and related to pregnancy where things can look as abnormalities of epithelial cells. Now, this is something which we might come across, and I have seen people making a lot of mistakes, right? So these are due to herpes simplex virus, and you see the cell with a very high NC ratio. It looks hyperchromatic if you're not really paying attention, but then if you look at it, you'll see it's actually not hyperchromatic. It's kind of a ground glass chromatin with margination of the nuclear outline. So if you are not careful, you might mistake herpes simplex virus cytopathy as cells resembling HSIL, and sometimes, as I've shown in the previous lecture, if the changes occur in bigger cells, like superficial intermediate cell, like possibly the cell over here, one might mistake it for L cell. So DDs of HSIL with hyperchromatic crowded groups would be atrophy, transitional cell metaplasia, groups of endocervical cells in tight clusters, groups of endometrial cells in tight clusters, lower uterine segment fragments, and ASCIL involving glands versus atypical glandular cells. I've dealt with most of them, but just a few of them here. So this is a hyperchromatic crowded group in atrophy. Most of them you have already seen. This is an example of a transitional cell metaplasia, a kind of a hyperchromatic crowded group. But what you see here, which helps us, are the presence of very significant nuclear, longitudinal nuclear grooves. Okay, so when you see them, this is one of those situations. If you're able to recognize, you'll see it once in a while. This transitional cell metaplasia looks like metaplastic cells, but very prominent nuclear grooves. Endocervical cells, especially in atrophy, can create the so-called hyperchromatic crowded group pattern. But once again, over here, you will be able to see that the polarity is pretty well maintained. The orientation is pretty good. Only seeing the cells have a scanty amount of cytoplasm. Especially in atrophy, they can look pretty sinister. But again, if you look at the polarity, they're well maintained and very sharp nuclear outlines. So all good over here. This is not HSIL. Endometrial cells in tight cluster can lead to hyperchromatic crowded groups. These are rounded ball-like clusters of cells. In the center, it is extremely tight. But if you look at the periphery, you will find that they're not really well focused here, but very sharp nuclear outlines and proper rounded nucleus, kind of a hobnailing pattern. This is not exactly a hobnail, but ball-like cluster of endometrial cells can give rise to hyperchromatic crowded groups. Now, ASCIL versus AI is a very, very difficult situation. We have already discussed before. So what are the things we are looking for to differentiate are things like this, that you see this, the edges, when the edges are sharp, okay, over here and not rounded, they're the straight edges. In the center, there appears to be an area of hyper tightening or whirling. But once again, the cells at the edges, you can see clearly make out the metaplastic cells, right? Whereas in case of adenocarcinoma in situ and other glandular abnormalities, which I am going to discuss in the next lecture, you find the cells, elongated cells, and they stand in a line. They'll stand in a line perpendicular to the edge. So you see, these are more of the columnar cells that you expect to find in adenocarcinoma in situ, right? Once again, adenocarcinoma in situ, kind of an elongated cells, right, with form a kind of an acinar pattern, rosetoid pattern, which sometimes may be seen in HSIL. This happened to come from a case which is later on found out to be adenocarcinoma. So there is a tremendous degree of overlap, and it is very, very difficult at times to differentiate between HSIL involving glands and adenocarcinoma in situ. Okay, many of the times this is only solved in biopsy, and as I've said, that sometimes both of them might coexist. So here again, an adenocarcinoma in situ with a kind of a something akin to feathering, and the most important thing is that you see the nuclei which are elongated and they stand perpendicular to the edges compared to HSIL, where they lie kind of parallel to the edges as you've seen before. Right, so this is just a table of HSIL versus adenocarcinoma in situ in hyperchromatic crowded groups. The features which are common to both and hence not useful in distinguishing the two are crowded groups with overlapping seen in both. Hyperchromasia seen in both. Mitosis, apoptosis may be seen in both. Right? So if you see that the arrangement is in syncytia, as you have seen in some of the slides before, is more in favor of HSIL, whereas if you see cells are mostly in sheets and strips, it is more of adenocarcinoma in situ. We are going to see a lot more of this in the next lecture. Whirling at the center and the flattening at the edges favor HSIL. Feathering rarely may be seen in HSIL. Roseting, it is said, is not seen in HSIL, but I have actually seen something which is close to a rosette in HSIL also, but more greatly favors adenocarcinoma in situ over HSIL. Strips of cells favor HSIL. Perpendicular nuclear polarization favors adenocarcinoma in situ, right? And nuclear cell for outline, if it is round and irregular, it favors HSIL, whereas if it is elongated, and especially if the orientation is perpendicular, it favors the AIS. But even keeping all these things in mind, putting everything in place, things can be rather difficult. Okay, now HSIL with features suggestive of invasion is something which has been described as situations where there are presence of highly pleomorphic cells with keratinized HSIL cells without tumor diathesis. This is a representative picture from the Bethesda Web Atlas. As far as I'm concerned, I try to do something, and that is if I see a lot of cells with HSIL in the smear, okay, I always try to put in a word saying that I cannot rule out an invasion. Okay, so here's is one of the cases. You see one smear, just see the number of cells just in one field. Okay, and there are many, many more. When I see a lot of HSIL on the smear, a lot of cells with HSIL, I usually put in this word that I cannot exclude an invasion. Of course, cases where there is no tumor diathesis, okay, or minimal diathesis. Now, the final part of the talk is the shortest part. We're going to talk about squamous cell carcinomas, which according to WHO can be of so many types: keratinizing, non-keratinizing, basaloid, warty, verrucous, papillary, squamotransitional, lymphoepithelium alike. Fortunately for cytopathologists, it is okay if you could just do this too. Okay, we do not expect to uh, diagnose things into these types on cytopathology. So these are the two major patterns which we see, which you recognize, right? Sometimes we may call something non-keratinizing, almost ready to call it non-keratinizing, and right in one corner you see some properly keratinized cells. So it also depends on the degree of keratinization. But anyway, there are two patterns: the keratinizing squamous cell carcinoma. Most of the neoplastic cells, remember, isolated. Cell aggregates are less common. In non-keratinizing, it's some way the other way around. So you see a lot more cell aggregates and less of isolated cells in the non-keratinizing squamous cell carcinoma. In keratinizing, isolated cells are more in vogue. Of course, there is keratinization. That's why it's called keratinizing squamous cell carcinoma. The cells can be markedly pleomorphic, and they show a variety of shapes, and those very well-known chordate and spindle-shaped cells, tadpole cells, all these are commonly seen in keratinizing squamous cell carcinoma. The chromatin may be opaque, granular, irregularly distributed. Chromatin lakes can show irregular nuclear outlines. Prominent nucleoli may be occasionally present. Okay, so you may find common nucleoli in keratinizing squamous cell carcinoma. Don't forget that. You can see them much more commonly in non-keratinizing type. So all those of us who possibly sometime during our residency believe that when you see nucleoli, it means it is glandular and not squamous. Well, it's not true. That's it. And of course, tumor diathesis, which is kind of a defining feature because it invades the stroma, creates a lot of necrosis, so that comes in the smear. So when you see a tumor diathesis, it means invasive, unless of course that exception which I spoke about a while ago, when HSIL cells involve glands that can lead to tumor diathesis. So this is a picture of keratinizing squamous cell carcinoma. No guesses. I mean, it's just absolutely clear cut. You've got very pleomorphic cell. Look at the chromatin, extremely hyperchromatic cell. Sometimes the cells with opened up chromatin, creating so-called chromatin lakes. Variety of chromatin, and you can see keratinization, some degenerated nucleus. These cells otherwise would be cells of HSIL, right? So this is a class and some degree of tumor diathesis in the background. This is a picture of a keratinizing squamous cell carcinoma, another one of a keratinizing squamous cell carcinoma, extremely pleomorphic cells, right? Hyperchromatic, irregularly chrome chromatin, and some opened up spaces, so-called chromatin lakes. They can be a very, look at this. This is what a chromatin lake looks like, absolutely clear spaces, in other words, hyperchromatic nucleus. And this is keratinizing squamous cell carcinoma. Right. There is, this I'm going to change when I'm going to provide you with the PDF. This is, I'm sorry about this, this is non-keratinizing squamous cell carcinoma. The cells are isolated cells are, many of them are in aggregates. So I'm extremely sorry, this should read as non-keratinizing squamous cell carcinoma. Isolated cells and cells in aggregate cells show high nucleocytoplasmic ratio, resemble HSIL cells. Irregularly distributed clump chromatin clearly, nucleolar may be prominent, and tumor diathesis extremely prominent, right? So it's an example of a non-keratinizing squamous cell carcinoma. You can see polygonal cells, okay, marked pleomorphism. Nuclear chromatin is a little bit more opened up compared to a keratinizing type. You can see more prominent nucleoli, and you have these presence of some dirty material in the background. And another example of a non-keratinizing squamous cell carcinoma, right, which with opened up chromatin and abnormal irregular nuclear outlines over here, some extremely hyperchromatic cells. These may sometimes be mistaken for, if you are looking at them in isolation, as a glandular lesion, but then if you look around to other parts of the smear, you're going to find typical other cells which show features of a squamous differentiation, like typical cells of high-grade cell, which helps us with the diagnosis. So with that, I thank you for your time. And once again, sorry for the little typos here and there. I'm going to be correcting them in the PowerPoint and the PDFs which are going to accompany the slides. And once again, thank you, Dr. Nadeem, for this wonderful effort in spreading the knowledge far and wide. And I'm extremely glad and proud to be associated with this. Thank you very much. I'll see you in the last of this group of lectures, and that is going to be on glandular abnormalities sometime very soon. Thank you.